Um, Thanks a lot for that, and thanks for the opportunity. And I'll start by apologizing to everybody who was here about 1 month ago for that disaster of an attempt to give a talk, and to everyone online who joined. And just thanks to Francis for the second opportunity, I guess. Thank everyone for coming here. I will say I have not worked on propensity scores. I've worked with propensity scores. So I'm not somebody who's done a lot of research on how well they work. I have done some work on a particular use or way to create propensity scores and its ability to account for unmeasured confounding. I'll get to that at the very end. So some of you may actually know more about propensity scores than myself. Some of you may know more about causal inference than myself. So as I go through this, it's not, there's the opportunity to interrupt and ask questions at any time. That's fine. But also the opportunity to interrupt and correct me when I've made a mistake. That would be great too. I'm sure everyone out here would like to know what the right statements are in regards to propensity scores and or their application. So a little bit about myself and some of the work that will be presented later. Let's see if I can get these to move. No, I can't. Let's just click in here. Now they're moving. All right, so yeah, I came from Winnipeg in Manitoba. It's that little red dot on the map. This is really far north. Winters get to about -35 Celsius, -40, depending on, just how cold it's been, up to +35 in the summer. So it's just extreme. Wreaks havoc on the roads, so I can say that it was very nice to move to Canberra. First, I didn't have to shovel snow, and second, my car is in much better shape than it was back in Canada. The place I worked at, Center for Health Policy, and one of the reasons that drove us to start to implement propensity scores in some of our research, it's an administrative data center. So this is government data. And it can incorporates all different types of data linked at the individual level. Really a world leading place in terms of diversity of data sets. We've got justice, education, all of your health, social housing, child and family services, everything's there. And just to give you an idea of the diversity, these are all different areas of data. All of the ones in the light tan are all health data, and then our gray ones are all different types of data. We tended to start calling them social data sets, but they're just different government departments. You've got your justice there. What were the other ones? Yeah, social housing, Indigenous status, Indigenous data sets, education, family services, income assistance, so your welfare data, all linked at the individual level for the entire population. All right, and so along came a day when I was doing a study and we were going to look at in utero antidepressants and neurodevelopmental outcomes in kindergartners. That's what it says, right? It's kindergarten here too, right? Is that? Yeah, okay, we do have. My kids were older when I moved here, so I honestly don't know if it's called kindergarten here, yeah. One of the things that happens in kindergarten in Manitoba is the application of the EDI, which also happens in Australia. So some of you may be familiar with it, the Early Development Instrument. So it was an opportunity to look at long-term effects of in utero exposure to a particular drug. Lots can be different between people who actually were exposed to SSRIs and people that weren't. And that was what drove our use of propensity scores. You'll find out why in a second. But I'm going to step back a bit and give everyone a brief review and some thoughts about causal inference in observational data research, really. And why it is that we ended up getting to propensity scores as a way to be able to try to make a causal claim about an exposure and an outcome. Okay, so when we're doing research, I think everyone would agree, we've got some population, really it's the population at risk for some exposure, I will say, not an outcome, that we're interested in studying. And in an ideal world, we would be able to duplicate that population in its entirety and be able to study that population exposed and study that population unexposed. That would be the ideal world. We would create a multiverse and an alternate reality. And in one reality, everyone was exposed. And in the other reality, that same group of everyone was unexposed. And we'd be able to compare the two on whatever measure we want to look at, and we would get a true unbiased estimate of the impact of the exposure. Fantastic. That would be the way things would go. We don't have access to the multiverse, or at least we don't yet. We can't create alternate realities. So instead, what happens is we tend to go to our population at risk and we identify a group of people that were exposed. We go back to that same population. We identify some sample of people that were unexposed. And then there we've got our two groups, an unexposed group, an exposed group. And what we're looking for is we want to compare the two of them on some outcome. We usually give the unexposed people a value of 0, the exposed people a value of 1. We want to look at some outcome, the relationship between the exposure and the outcome, and we have our little regression equation. Our outcome y is equal to some intercept plus beta 1 x1. And you can add the error if you really want to. I'm not going to do that right now. What we're interested in is a beta 1, and that's our estimate of the impact of the exposure. That's what we're able to do. And unfortunately, when we want to look at that beta 1 and its impact on the outcome, because we haven't got access to alternate realities, there's this introduction possibility of confounding. And I'm going to state this here, although I probably don't have to, but I always feel the need to state it. A confounder is something that is related to both the exposure and the outcome, not just one. So if something is related to your outcome, but you can't imagine how it could be possibly related to your exposure, it is not a confounder. There's something else related to your exposure, but you can't imagine how it could possibly be related to your outcome, that also is not a confounder. Could make a great instrumental variable if you're into, that kind of instrumental variable work with two-stage least squares. The confounders are the real issue. They must be related to both. And so to deal with them, you can either remove the relationship to the exposure, or you can remove the relationship to the outcome. I said that backwards. Sorry online. Sorry in the room. So you either remove the relationship to the outcome, or you cut off the relationship to the exposure. A lot of research with observational data, at least in the early days, but wasn't matching, remove the relationship with the outcome. And that's simply by expanding your regression equation to include all of your covariates. So now your beta 1, which is the one you're interested in, it's conditional on the mean value pretty much of all your other covariates. And so you've removed the impact of your other covariates on your outcome. And now you supposedly have a unbiased estimate of the relationship between exposure and the outcome. And that's just a regression model approach. Roll your measured covariates in, you're good to go. There's a lot of, I would say, preferable ways to do things, and that is to remove the relationship between the confounder and the exposure. Because you're not trying to throw things in at the outcome analysis stage, and some of the things that you can discover and find out by working on this side of the confounder relationship can help explain some really weird things that can happen when all you do is regression analysis. So one of the first ways to get rid of this path was the RCT, randomized controlled trial. You get your people into a study, you randomly assign them to be exposed or unexposed. You get a large enough group of people, and they will be the two groups on average equivalent on all possible confounders so that you can measure or unmeasured. And so you've cut off that path between the confounder and the exposure. An RCT does not try to address the relationship between the confounder and the outcome. Right? Old people are still more likely to have poor health outcomes than younger people. And you can have older and younger people in the same RCT, then you just don't care. And you don't have to care, because the relationship between age and your exposure is nil. So you cut off that path, you can just go ahead and run a simple regression, a simple analysis, you're good to go. Instrumental variables, I already mentioned. You can do a two-stage least squares. I haven't done this as much. I think I've only done it twice, and that was quite a long time ago. It's really hard to come up with instrumental variables in health, or at least we always thought it was. Some people have started to think that you can. Usually the issue is that an instrumental variable should not be related to your outcome in your analysis, or any relationship is only through your exposure. And that is really hard to come by or hard to justify. And the other issue is to just get one that's strongly related to your exposure that you can measure. I've just done a lot in econometrics, I know. The RCT is really a special case of the instrumental variable where you have a perfect instrument. It's 100% related to your exposure and not at all related to the outcome except through the exposure. You've got the ideal scenario. And so in health, especially in observational data, there's a lot of situations where you can't run an RCT, like the example I brought up at the start. So if you wanted to look at the effect of antidepressants on the fetus, that's going to be hard to do, to justify through an ethics trial to say, hey, we think there might be something wrong, so we're going to give some women randomly an SSRI or an SNRI, and they're going to take it, and we'll see what happens later on. There's lots of other scenarios where that's also the case. And the universities, granting agencies, and the corporations that produce those drugs just don't want to get into it. They're never going to run an RCT. They almost never run RCTs on pregnant women. They almost never run RCTs on children. Usually what happens is the drugs are approved in a sample of adults. That's where the evidence comes from. And then they just start getting used once they're approved in other groups. So we're stuck in a scenario where we can't run an RCT. Many times you're stuck in a scenario where you haven't got an instrumental variable that you can point to that would accomplish the goals of an instrumental variable analysis. And so let's try to come up with something else. Now, both of those approaches really affect the likelihood of being exposed, right? Or work with the likelihood of exposure. The instrumental variable, once you've used it in the first stage, now your exposure should be independent of covariance. So that your likelihood of exposure is essentially random, or should be random. Since you're talking about the likelihood of the exposure, you can actually just go ahead and measure that. Measure the likelihood of the exposure. A little bit like two-stage least squares, but not really. We're just going to take a step back and we're going to talk about the exposure variable and run an analysis on the exposure variable. And it's just a logistic regression model. That's all you do, right? I'll replace that with the logit of the exposure. We're just running a logistic regression on the exposure. So it's a 0-1. Was a person exposed or not? In other contexts, were they treated or not? Were they part of an intervention or not? It's always going to be that binary outcome. Incidentally, it can be expanded to multiple categories. Pretty straightforward extension, but it was developed and really mostly used with that binary expression of exposure. That model can have all the variables in the world in it. You're not really too concerned about some of the satisfaction of assumptions of a model. You really don't care too much about it, other than you probably still want to pay attention to not having too many variables for the analysis. So that little rule of about 10-1 for your events for each covariate in the model. Although a more recent simulation would say it's 5-1 after you have a large enough number of events. Now you've got a logit associated for every person of their likelihood of being exposed. And then we don't want to use the word probability because usually in health, your outcome is binary and there's a probability of the outcome happening. So we just switch the word to propensity, but it's the same. Propensity is just a probability. but it's the probability of the exposure instead of the probability of the outcome. So now we've got a probability that a person is exposed. That's all we have at this point. You still have to do something with it. So now we've got our full data set with all of our variables. And in addition, we've got some logit or a probability that a person is exposed. There are a number of approaches. There's weighting, matching, stratification on the propensity score. I've seen people use it as a covariate in regression, although based on what I just said, never do that. That's not something you should ever do because it really flies in the face of the whole reason that you're building the propensity score, which is to remove that relationship on the left-hand side. I've used both weighting and matching, and I've got the example that's going to come up is going to be using weights, but there's also, you can also use them to match. You can match on that propensity score. The inverse probability treatment weight, people are familiar with it. Essentially, it's just 1 over p, where p can be one of two numbers. It's the probability that you are what you are. So for exposed people, it would be the probability of being exposed. For unexposed people, it would be the probability of not being exposed. That's all that the weight is. It's really straightforward. Nothing too complicated about it. It will give you an average treatment effect when it's applied in your outcome model. And the average treatment effect is actually what you get in an RCT or when you use covariate regression. Right? In both cases, you're getting, although a lot of people don't really realize what you're doing is you're creating a scenario where everybody in your sample was exposed compared to a scenario where nobody in your sample was exposed. If we go back to that ideal world above, this is what you're trying to do. Let's create a world where everybody was exposed, a world where nobody was exposed, and get an estimate of the effect between them. That's what an RCT does. Okay. Regression adjustment does that. I think it's conditional on the mean overall of your entire sample. Right? This is when you include a covariate. There are other kinds of weights for other kinds of questions. Sometimes you don't want to know an average treatment effect. What you want to know is what was the impact of the exposure on the people that were exposed. You don't want to know about, oh, everybody that was exposed and everybody that was unexposed. You just want to know what happened to those people because they were exposed. You can develop a weight for that. Essentially, everybody that's exposed is a 1. So they get a weight of 1. And everybody that's unexposed gets a weight that will actually make that unexposed group look like the exposed group. So now your alternate reality is, here's my exposed group, and I can measure them under the exposure. I've got it. That's the observed data. I'm going to take my unexposed people, make them look just like the exposed people, and we'll measure the outcome in the unexposed group. So it's a little bit different research question than the average treatment effect. And there are scenarios under which you want to know one or the other. And if you're more interested in the treatment effect amongst the treated and you're going to make statements about the treatment effect amongst the treated, that is, what happened to these people because they were exposed, you need to make sure that you don't use the straight IPTW, which is more frequently used, the inverse probability of treatment weights, that you don't use regression adjustment conditional on the means, because that is going to give you an average treatment effect. It doesn't give you a treatment effect amongst treated. So you want to make sure that whatever analysis you're doing it right. So it is the treatment effect amongst the treated. Really higher weights are given to the untreated individuals who look like the treated group. That's what will end up happening. Right? In the inverse probability of treatment weights, the higher weights go to the people that look like the other group. So you're upweighting the counterfactuals that give you a lot of information about what would have happened in that alternate scenario. And really not downweighting, but they don't receive as much of a weight. The group of individuals who really got the exposure to the treatment that you would expect them to have. Yeah, I talked about that already. Now, what else do you do? So now you've got it, you've got weights. Before we even use the weights, you want to take a look at your exposed and unexposed groups. And typically, we would usually do some trimming of the analysis there. And you trim based on the probabilities or the propensity scores for the exposed and unexposed group. This is usually done to avoid having extrapolating beyond your data. So you usually want to make sure that you have somebody in the neighborhood that's unexposed for everybody that's been exposed, and the same the other way. It also helps to avoid really extreme weights that can result. So you can imagine a case where somebody wasn't treated and, was treated, but the probability of being treated was really, really low. They're going to end up with an enormous weight. And it can really mess with your analysis, just like any other outlier in a sense, right? They're going to have undue influence on your analysis. So we tend to trim. Sometimes it goes by percentile, eliminate the 95th percentile and above of the exposed group and the 50th percentile and below of the unexposed group. So it gets rid of all the really low probabilities and all the really high probabilities. And we're just going to keep that group in the middle, for which we know we've got a counterfactual, right? All of our unexposed people, we have somebody like them to some degree that's unexposed, or at least in their overall probability of being exposed. Another thing that you can do and you should do along the way is estimate the effectiveness of the propensity score treatment, whatever it is that you're doing, whether you're matching or weighting. This has frequently been done using standardized differences. I think not everybody has been familiar with standardized differences when I brought it up. Essentially, it's a p-score agnostic way of comparing the groups and how similar they are, which can be really important in observational data because for a lot of variables, groups are going to be different because your sample size is huge. Right? If you try to run a simple analysis, they're going to look different. But it's only because you have a really large sample. Standardized differences are sample size agnostic anyway. Those standardized differences having a value from 0 to 100. It's actually the absolute value of the standardized differences because it can go below 0. If the exposed group has less likely to have some covariate than the unexposed group. So it's the absolute value of that formula there. It's calculate the standardized difference. And this, you usually want to be below a value of about 10 or 10%. So I've also seen people use the word percent. Peter Austin at U of T has done a lot of work with propensity scores, and he's looked a lot at when you have really that negligible impact of a variable on your analysis. And below 10, you're really good. So you want to get as close to that value or below it as you can manage. So it gives you an opportunity really by developing that propensity score to first make sure that in the multivariate space, your exposed and unexposed groups, you've got coverage, right? You've got a counterfactual, and also to look at whether or not the groups are similar or different after you've applied that treatment. You could do it with any other method that works on this side. Can't really do it with two-stage least squares. Can't really do it with a regression adjustment. How do you figure out whether the same or different? It's difficult. Okay. The example, in utero antidepressants and neurodevelopmental outcomes in kindergartners. So we'll get to the meat and the crux of it. That was a little bit about how we got to propensity scores in health anyway. Hopefully everybody's followed along. And I haven't said anything too wrong. So this was published in Pediatrics, in 2020. Okay, so it's about 4 years ago now. And prior to that, we've done a study looking just at drug utilization in pregnancy. And one of the things that we found, and this is true just about everywhere in the world, is that psychotropic drug use during pregnancy is increasing. It's been increasing for the past 20 to 30 years. May have been increasing before that, but most comprehensive databases on dispensation data really took off in the mid-90s when the personal computer did. That's when people were able to start entering data, and the requirement was put in that pharmacies had to record dispensations. So what we see is an ever-increasing use of different types of drugs during pregnancy. For psychotropics, your SSRIs, SNRIs, other antidepressants, antipsychotics, benzodiazepines, even opioids. We even identified a cohort of women that had taken all of those during a pregnancy, which I found surprising, but maybe I shouldn't have. When you have the whole population, you're going to find some people who just happen to get a dispensation for every drug under the sun during their pregnancy. I'm not sure what the doctors were thinking, but they weren't included in any studies anyway. So yeah, about 20% of pregnant women are diagnosed with depression. Around 15% are getting antidepressants during pregnancy at the time of the study. Mostly it's SSRIs and SNRIs. So your first step, and then the SNRIs like mirtazapine and others. And there is some evidence that that exposure in utero does affect the fetus. There's actually been lots of studies that have looked at this. And they've linked it to various different things. So the scary things for parents like autism and ADHD and other things. Does it really? Well, a lot of observational research isn't actually done very well. There's a lot of it that can't address some of that confounding. Some of these studies were comparing women that took an SSRI to women that didn't, and it was the whole population of pregnant women. And in pharmacoepidemiology, we would say there's an issue there, and that is confounded by indication. So the reason that people take a drug usually is also related to whatever outcome you want to look at. And that is the case here as well. Being depressed does actually have an impact on the fetus as well. There's been enough observational research to show that relationship as well. And that has a lot to do with, I guess, brain chemistry and other issues affecting the whole body as a result of depression, right? So some of the limitations, even when they have been able to restrict it, can't account for disease severity, haven't got really long-term follow-up. A lot of them have small sample sizes, and there's an inability to control for maternal genetics. So it'd be great to be able to control some of those other things as well. One of the things that we can use is you've got a good integrated set of data is educational outcomes for your long-term results. You're not going to get all of these kinds of in-depth work on a large sample, but everybody goes to school. So maybe you can use some of the data that comes out of your educational data sets to be able to look at the longer term effects, as opposed to just the really short term things that you're able to measure in the hospital. The EDI, as I pointed out, yeah, it's used all over. It was developed in Canada and is actually used more in Australia now than it is in Canada. It's called the Early Development Instrument. Oh, it's still called that here, but it's part of the Australian Early Development Census. That's what the C is. So it actually gets used here everywhere as well. This work could be replicated. So again, we run into the same issue here, right? We've got exposed people that took an SSRI, unexposed people that didn't take that SSRI. We want to look at these neurodevelopmental outcomes on the fetus, but there could be confounding along the way. The confounding issues are pretty big here because, you know, a person who takes an SSRI probably has a health condition that might also be related to these neurodevelopmental outcomes for the fetus. Could be other drugs they're taking, other factors that are associated with the likelihood to be taking those prescription medications. So we want to come up with some way to address this confounding. In this study, one of the things you can also do along the way in your research is to restrict your cohort. So remember when I said at a certain population and I added at risk. So when we did this study, we weren't going to look at all pregnancies in the province. We restricted it to pregnancies where the mother had a recent diagnosis for mood or anxiety disorder before conception. So in the 3 months prior to conception, somewhere in the data, there's a diagnosis for mood or anxiety disorder. So that's going to be our population at risk. That's a population for whom you may or may not consider taking this SSRI or SNRI. There's other indications for using those drugs. We're not going to try to tackle those ones. We're going to tackle a population of women with a mood or anxiety disorder. So that took us from about 250,000 pregnancies down to 12,000. Well, actually, one more thing took us down to 12,000, and that was we dropped any women who filled one dispensation for a drug during their pregnancy. That's because the data only records dispensations, doesn't know whether or not women actually took the pill. And a single dispensation, the woman may or may not ever touch them. This is true for all pharmacoepidemiology work. If somebody gets a dispensation, you don't know they actually took it. We tend to ignore the dual or the second dispensation in terms of antibiotics. We like to think that people are prescribing antibiotics for a reason and they take it. That may not be true. But for these kinds of drugs that you should take for a longer period of time, we want to see that second dispensation. The assumption there is that they finished the first one, which means they took at least the number of pills that were in the first one. They may not have taken any of the pills in the second one, but we know they're exposed. So it reduces that measurement error, right? That misclassification, actually. Because if you were going to treat them all as exposed, you'd probably have a considerable chunk that are actually unexposed. You're just contaminating your data. So our unexposed group didn't have any dispensation, for their exposed group had at least 2. I will say, in Manitoba, all dispensations are recorded, no matter how they're paid for, no matter who you are, everything's recorded. So that I'm not sure that that's always the case here, that every dispensation hits the data, no matter how it's paid for. But that is the case in Manitoba. And that's regardless of whether or not, you know, you're a permanent resident or everybody. It's all recorded, every single dispensation. So what are we going to do with this information now that we've got these 2 groups of women? All we've got is observational data, which is great. What we did was applied something called the high dimensional propensity score. And this is an automated procedure for deriving a propensity model that was developed by Rassen and Schneeweis, although I think this paper is Schneeweis and Rassen. I think Jeremy did more of the work on it, actually, but Sebastian is definitely the more senior researcher. They're at Harvard. It was a way to essentially have your scan all of the data that you have access to for your group that you're looking at and identify any exposures that the person had. I'm not talking about the treatment exposure, but anything in those dimensions, look at whether or not they're related to the exposure, also whether or not they're related to the outcome, and develop a propensity score. And it will decide your variables for you, as opposed to trying to come up with one. A lot of propensity scores are investigator driven, right? You think of the things that are confounders and you go and try to measure them, or you ensure that they're measured and you put them in your propensity score. This is an automated method for observational data to derive that propensity score for you. And it can do some pretty fantastic things for you if you take a good look at it. So yeah, it selects confounders that are relevant, and it prioritizes them. And it actually runs a reduced model on the full set of possible covariates, and it only includes the top ones for their likelihood to introduce bias. To give you an idea of what a dimension is, it's just a picture. That's all it is. In their speak, they're calling it dimensional, but their dimensions, at least when we ran it, were 5 dimensions, if you want to call it that. One was medical service tariff codes, which here are called fee codes. So that is the number associated with the bill that the doctor sends to Medicare every time they see you. And different types of visits have different fee codes. And one visit can generate multiple fee codes. So the doctor will get paid for every little thing they do, and there's different tariffs associated with them. Physician diagnostic codes in Canada and everywhere else in the world except for Australia, you get ICD-9 codes with your physician data. So you can use those diagnostic codes as well. Hospital procedure codes, hospital diagnostic codes, somewhat similar. Hopefully people are familiar with those. So the things that are done in the hospital and diagnoses that are identified while you're in the hospital. And finally, prescription medication claims. So a whole bunch of different types of health data. Using all this data, what we're hoping to do is account for any differences in the mental health comorbidities that women may have between exposed and unexposed amongst depressed women. Chronic diseases, there could be other conditions that they have, medication use. So, everybody had a diagnosis of depression, but some women might be going into their pregnancy already using an antidepressant, and other women weren't using an antidepressant. And then the number of hospitalizations and physician visits, really to account for some of those other conditions that could drive use of an SSRI or SNRI. I talked about standardized differences. This is what the change to standardized differences looked like before and after applying inverse probability treatment weights. For this study, our trimming, we actually trimmed out anybody with a probability less than 0.02. So any person that had less than a 1 in 50 chance, according to the model, of being given an SSRI or dispensed multiple SSRIs during the pregnancy, was taken out. And then it was also, I think, the 95th percentile and above on the exposed side, which I think was around 0.8 or so of likelihood. That was really because, we were trying to answer a clinical question, right? So amongst a group of women for whom there could be a debate, should we give them an antidepressant or not while they're pregnant? What's the impact of that antidepressant on the fetus? So for women with a really, really high probability of being dispensed an SSRI or SNRI during their pregnancy, it's probably better for them to be using it during their pregnancy than for them not to be using it. So it's not a clinical question for them. And it's the same with the really low probabilities, right? They probably shouldn't be on an SSRI or SNRI, so let's not bother with including them in this question here. You can see almost all of them went down. And went down a lot. I think there's one that doesn't even show up on the graph here. Yeah, the psychotherapy by non-psychiatrists. The before standardized difference doesn't show up. Afterwards, it's just above that negligible 10%. Still really low. So that's what you like to see with your propensity score. After you've applied it, whether it's weights or matching, you want to see that those differences between your groups on average become negligible. That's trying to get at cutting off that path between the confounder and the exposure. So now in my model, there's really no relationship between these covariates and my exposure status. Let's see. Oh, there's one I'm going to point to. It's at the very bottom, and there's one further up as well, where standardized difference actually increased after the application of the propensity score weights. And you'll tend to see this when they were already the same. Now, it still got put into the model because there was some identified potential for bias, but this can happen in a propensity score model, and watch out for it. Sometimes you'll actually make all of your differences larger. It tends to only happen when the groups were basically the same at the start. And if you calculate your standardized differences right away, you may not even need to do this propensity score stage. Because if you find out your groups are the same, go ahead, you're good to go. Don't need to do all this other work. It's a lot of effort for not much gain, and potentially introducing actually errors into your model, right? You've got the potential, if you're not really careful, to introduce colliders. Who wants that? So logistic regression analyses were run on a bunch of outcomes. Yeah, we don't need to worry too much about them, but there was a couple of them that showed some relationship. One of them actually had basically the same relationship before weighting as after. And the other one actually showed a real increase after applying the weights in the effect. And you'll see for some of the others, there was a decrease, and for a couple of considerable decrease in the odds ratios associated with those. That worked out really well. There were additional analyses that were run, including negative controls. So this was, so for people who aren't familiar with negative controls, it's where nobody in your study group was exposed. What actually happened is we compared women who had been on an SSRI prior to conception to women who hadn't been on an SSRI prior to conception. So you're kind of extending this notion of, is it the actual exposure at the time of interest that is impacting the fetus, right? These were women who had been on before. And the half-life of SSRIs is pretty short. So it should wear off very quickly, particularly in that window of time when it could impact the fetus. And so what we found there, importantly, was no effect, right? That's what you'd expect to see, because nobody took an SSRI or SNRI during the pregnancy, so there shouldn't be a difference. So it's nice to see as well. This study adds some stuff. Yeah, that's great. What time do we have?
15 minutes maybe.
15 minutes?
Yeah.
So I'm going to speed through to something else. We can get back to questions on this, but I'm going to speed through to something that's looked at in utero opioids. And the reason I'm doing it is because the approach is completely different. We looked at, again, no opioids versus 2 or more opioids. Now, for depression, we were able to restrict, or sort of for the SSRIs, restrict a cohort to women who were depressed. Turns out with opioids, you can't possibly figure out why somebody gets prescribed an opioid. You can try, but it's not going to work very well. When people see the doctor and they get prescribed an opioid, it could be anything under the sun that shows up on the visit codes. No idea. And so this is a scenario where we had to use the whole population. But it turns out we actually didn't want to answer the question, what if every mom had an opioid versus what if no mom had an opioid? We actually just wanted to know what was the impact of the opioid on the women who had an opioid, or what's actually on the child. So we matched. You take your exposed group and you're going to find people who are unexposed who look like this exposed woman. So somebody who's as similar as possible in the likelihood of getting an opioid as the woman who actually was prescribed the opioid. And that caliper distance is 0.2 times the standard deviation of the propensity score. When you're doing the matching, I will note you match on the logit. don't match on the probability. It's a little bit different from using the weights. And again, we had the same health dimensions and we introduced some demographic values as well. One of the interesting things about, I'm going to skip through this and just get to this here. As an aside during this analysis, we wanted to see if the propensity score could account for unmeasured confounders. So other things that might impact the outcomes other than health, which is the information that we were using in the propensity scores. As I pointed out earlier, we had all of this social data. Included things like whether or not you were on income assistance, your history of child and family services involvement, so that's whether or not you had a child taken into care or not. History of teen birth, so not is this birth your teen birth, but have you had children while you were a teenager? Ever in social housing? I think that's the same here. You call it social housing?
Public housing.
Public housing, there you go. Residential mobility, so that's moving around a lot, because in data you can see every time somebody moves. That's also not a good thing. Contact with the justice system. We use contact because, well, there's 3 different versions of contact in the data. There's being the perpetrator, or sorry, I should say the accused in the data that we have, the victim, or a witness. And it turns out that no matter which one of those 3 you are, it's not good. Most witnesses are not random bystanders, they're right in the mix. And so it's not good to be a witness either. It's probably not good to be the victim. And you're definitely, there's problems and issues if you're the perpetrator or the accused. And then, yeah, lowest income quintile, you've got income, so you can look at that. So we just use our health data and develop a propensity score and now measure how similar these groups are after we apply the propensity score. These are our new standardized differences. They shrink a lot. They're not perfect. They're not below that 0.1 line, but if we take a look at with and without the propensity score that only used the health data, didn't have any social data at all, it really does capture a lot of these other unmeasured confounders in a sense. We went further, added some of this other data one at a time, and it turns out that if you just are able to get income assistance as well, you've got it covered. You don't need all that other stuff. And that other stuff actually doesn't do near as much as what income assistance does. So if you can get your health data and income assistance data, you've accounted for a lot of other potential confounders, particularly those social determinants of health typically are not available in health data. So I'll just leave it at that and take questions, comments, or criticisms.
Hey, thank you, Dan. We've got plenty of time for questions. If anybody would like to ask a question.
Oh, you said 15 minutes. That's lots of time. Okay.
You finished in about 10.
Oh, okay. Great. Hey.
Thanks for the presentation, Dan. I'm Ben. I'm over the Centre for Indigenous Policy Research. I think I'm just inherently skeptical of data-driven decisions in causal inference scenarios. And has there been much of a comparison between how high-dimensional propensity scores translate back into a DAG, directed acyclic graph, and how that compares to expert knowledge created DAGs? Because
Yeah, I'm going to say no. There has been work with the high dimensional propensity scores to look at, I know there was a study that actually looked at it in relation to an RCT on the same set of subjects. Can't remember when that was done. It gave very similar results. One of the things that comes out of the high dimensional propensity score is things that experts would never think of. So if you're looking for them to be similar, they won't be. And I said earlier, you can actually learn things from the propensity score, that's that machine-driven one. One of the things that we learned on a study on a psychosis intervention, when we took a look at some of the top medical diagnoses that were coming out, so it actually produces for you all of the covariates that are in the propensity score, whether they're ICD-9 codes or dispensations or hospital procedures. I tried to turn them back into English for that figure. One of the things we learned in that psychosis study was differences in diagnoses of vision disorders and skin disorders and auditory issues. And in hindsight, they were all really symptoms of psychosis prior to the diagnosis of psychosis. And it's not something that any of the psychiatrists on the team are actually expecting to see, that we're getting these weird diagnoses that are associated with whether or not you end up with psychosis, and as part of the early prevention effort for psychosis services. So you can learn a lot from them. I think that a lot of it looks, when we looked at the antidepressant one, most of it looked really like what you'd expect to see. So it was visits with a depression diagnosis, hospitalizations that included the depression diagnosis, use of SSRIs or SNRIs, visits that had counseling associated with them. So the fee was for counseling. So in that sense, I think that it's exactly what you'd expect from an expert version. It just doesn't count for each of those diagnoses or procedures or interventions, and it divides those counts into happens rarely, happens a lot, or which decile they're in. And so you may have only the highest are actually considered for the final model, and others it's all of them would be considered for final model. So you can have multiple appearances of the same variable. When I said that it automatically looks for these variables, so when I said the medical claims, what it does is everybody in your whole sample, it looks through all of the diagnoses that anybody got in the whole year prior to conception, and then looks for that diagnosis in every single person and divides it into didn't have it and those categories of frequency. And then takes a look very simply at the relationship with the exposure and the relationship to the outcome. And there's a pretty simple formula for a potential for bias, and it ranks them on the potential for bias. That also includes the prevalence in it. So something that almost never happened isn't going to produce much bias in your estimate because it just isn't in your data. So it's the prevalence of the covariate or potential confounder and its relationship to your exposure and relationship to the outcome. And it prioritizes based on the potential for bias. The default settings are 200 from each dimension, and then a total of 500 in the final model. If you don't have really huge data sets, you can change those defaults. So in the psychosis analysis, I think we set it at 20 from each dimension and 40 in the final model, because we didn't have, luckily, a really large sample of teenagers and young adults with psychosis. That's the answer I'll give you. If you don't like machine-driven methods for
I'm
identifying.
just curious if they're like sanity checks, like do you produce
Oh yeah,
a graph which
when it
tells
puts
you
that
where-
out and gives you the ones that are included in the model, go through them. Don't ignore it. Go through them and say, does this make any sense at all? And that potential for bias score, very quickly, it hits basically nil potential for bias. So, the default is 500, but I think in that analysis, after we hit around 40 to 45, potential for bias started getting really low. These things weren't really highly correlated either with the outcome or with the exposure.
We have another question in the chat, which is regarding the standardized differences, were all covariates continuous or some were binary categorical, yes, no?
Yeah, some are binary. In fact, I think most of them are binary, and there is that wasn't a great formula to put out there, but there's a adaptation of that formula for calculating the standardized difference on a categorical variable.
Thank you.
Yeah.
Any other questions online or anything? Yes.
Just wanted to understand the method steps. I think your result estimates are odds ratios.
Yeah.
So going from you've applied your weight or your
So the weights are being used
Getting
in that
to the
outcome
odds
model. Yeah. Sorry, I interrupted you.
No, sorry, I missed the start of your answer.
Yeah, so after you develop that propensity score model and you turn it into a weight, those weights are then applied in the outcome analysis. So in the outcome analysis, the weights to the exposed group, turn them into, if you're using the straight inverse probability treatment weights, they're weighted up so that they appear to be exactly like your whole sample, exposed and unexposed together. And the unexposed group is weighted up to look like the entire sample as well. On all of the covariates that went into the propensity score, they will be similar. So never include your exposure in the propensity score. And don't include anything that's happened after your exposure in your propensity score. And it's all stuff prior to exposure. And surprisingly, sometimes people will start to include stuff that's happened after the exposure. Shouldn't do that. If at all possible, you only want to look at things that occurred prior to the exposure.
Any other final
Can I ask
questions?
a
Yep.
question about missing values with these numbers of confounders? There must be a lot of missing values floating around, particularly in the larger data sets. You have to whittle down to the ones you're particularly interested in. You know how the system handles that?
Yeah, so because it's looking for these fee codes or diagnoses, the data that we have, and I'm not sure that this is entirely true here in Australia, it is every visit to a physician. In Canada, it's illegal for physicians to charge more than the Medicare reimbursement rate, so nobody ever pays to go to the doctors. So the doctors have to bill the health ministry if they want to make any money, right? That's the only way they get an income is by billing the health ministry. So we assume if the fee codes or the dispensations or the diagnosis doesn't appear for that person, that they didn't have it. It's a true zero. It's not really like a survey data set where you can have multiple reasons for why it doesn't appear, some of which is that the value is truly missing. So the assumption is made for the most part that whatever that particular covariate is, it doesn't appear for that person. It's true zero. Every dispensation is recorded, as I said. Hospitalizations are 100%. Because there's no private hospitals, and it's the same is true of the physician visits. It's all present in the data. They even get, like, if you go to another province and go see a doctor, because that province wants to get their money back from the province you're from, that data comes back to the originating province where the person resides. So you end up.
Any other final questions?
I have a quick one building on that.
Yep.
If you had missing data, what would you do?
Well, it's related, so it's more to do with linkage errors, because this is based on data linkage, right? Is there a way to incorporate linkage errors? And I know that it's very difficult to know when your data linkage is wrong. Especially when you're the one doing it.
So
populations.
We don't do the data linkage. So you're right. So there's a group of people that do all the data linkage, and they're at the ministry. Although for linking a lot of these data sets, the center I was at sent their analysts to the ministry to work in the ministry to link the data sets because we didn't trust them to do it well. For the most part, we're really confident with the data linkage because you have the name, the address, the date of birth, sex. You have those really key important variables for linkage. And almost always we end up with a perfect linkage on those. There are flags for individuals with in each data set where the linkage is more suspect. So where we have the name is the same and the address, but the age is wrong. We still think it's right, but in one or the other data set, they've recorded the age wrong. When you delve into those, you'll typically see that what's going on is somebody's transposed one of the either the day or the month is backwards, or they typoed the year, or because there's particular spikes at particular values. I there will probably be some way to incorporate it. We never have. I'm just
Yes, you
thinking
look at
about,
how.
you know, like I would probably, my temptation would be to have a good idea of those really good linkages and ones that aren't, and run a sensitivity analysis,
Yes.
right? Where you take them out and see if things change a lot. Yeah, that would be my temptation.
Daniel Olazar from the ABS. So I've looked into this. I'm really interested to know if any agency in the whole world actually measures linkage error. So Ray Chambers has done a lot of work theoretically on this, but has had to make some pretty strong assumptions. But what you'd have to do is capture all the alternate possible links, like a bipartite graph, and use probabilistic linking where you get some sort of estimate of the probability of the match. And there are ways, so it's still a very, there are ways of incorporating linkage error into regressions, but from what I know, it's mostly just, linear regressions. So there's a whole lot of work to do there. I could give a seminar, I'm planning to give a seminar.
Yeah. So, for those of you online, the comment here is when it comes to linkage error, somebody has looked at it. And one of the things that comes up is you need to then determine, if something isn't, or it's a suspect match, what are all the other possible matches that it could have been, and did any of them have a high probability? So it could be the case that even where your match seems low, there's just nobody else in the data it could have been. So you're probably right.
Fine. And
yeah.
So many of our admin data sets, like 60–65% of matches are like that. There's no other contender at all.
Yeah.
But when you're dealing with crime and justice data, where people have aliases, and move around a lot, then
that's something we discovered in justice data as well. It's really tricky. I mean, it's great if they're incarcerated, because then their personal health number follows them, and then you can link them perfect because you have their personal health number. But if they're not incarcerated, there is a little bit more of an issue there. And one of the things with the linkage when I talk about address is it's the address that's on file with health. And sometimes people aren't too quick to notify health when they've moved. And so one of the first questions anytime you have a health interaction is, is your address this, or has it changed? And so those updates may get back to the system, but sometimes people just lie as well. So I actually did an analysis on primary care, and we were taking a look at, it was for primary care networks. We wanted to take a look at where people were going for care, because if they were going to develop a network, a virtual network of providers that would care for a population of patients, it's the default tendency is to say, where's the person live? But if the person doesn't go there for their care, then that could be an issue. And we had some people whose most common provider was, 1,000 kilometers away. So clearly the address on health is wrong, right? They don't live where you think they live anymore. They're living somewhere else. So the linkage is still good there. But the health data has the wrong location for them.
Okay, I think we should probably wrap it up. So let's thank Dan again for a very interesting talk.